Welcome everyone. So today in this short video we are going to learn about the basics of how to classify a dysmorphic child or a child with dysmorphic features. So before we begin to classify a child with dysmorphic features, we need to gather adequate information about the child so as to help us with the classification. What is that information? So first thing is we need the adequate family history. We need information about the gestational timing or the gestational age at birth. We need to know about the indications of uterine constraint. What was the mode of delivery? What was the size of the baby or weight at birth? How was the neonatal adaptation? That means the switch from the extravitreal life to the intrauterine life, was it smooth or was it hampered by some life threatening events or any other events as such? Were there any problems in postnatal growth and development? What is the physical examination findings confirming our major and minor anomalies? And we have to do some measurement to confirm the features, whether actually those features are present or not. For example, if we are thinking that the child may be having low set here, we need to objectively classify or we need to objectively confirm by our measurement that the patient actually has low set years. So after gathering adequate information, we need to ask ourselves three basic questions, and all the three questions are from the viewpoint of developmental anatomy. So the first question is, which anomaly in the individual represents the earliest defect in morphogenesis? Why is this question important? Because the answer to this question will help us localizing the time from which the pathology had started. For example, suppose a baby is detected to have a congenital heart defect, and the mother says that when you ask for the antenatal history, the mother says that when my 34 or 35th week of gestation was going on, I had developed a fever with rash. So, could that infection have caused the congenital heart defect? So we need to ask ourselves, we need to ask the mother this question, because we know that the development of heart occurs around 8 to 10 weeks of gestation. Basically it starts from the third week and the completion is by 8th to 10th week. So if the child is having a congenital heart defect, that means the interruption or the problem or the insult might have happened within that period only, not at 34 weeks. Any insult after the development of heart cannot cause a defect in the heart. So the answer to this question will help us localizing the time of insult. Second question is it a sequence? Third question is it a syndrome? Syndrome is also known as malformation syndrome. So to answer all these questions, basically is it a sequence or is it a syndrome, we need to understand what those are and we need to understand the definitions of that. So coming to the definition of sequence, what is a sequence? Sequence refers to the condition in which all the anomalies in the patient can be explained on the basis of a single problem in morphogenesis that leads to a cascade of subsequent defects. That means when we call it a sequence, we call it a sequence when there are multiple problems present in the patient, but all the multiple problems have started from a single problem in morphogenesis initially, and that single problem by a cascading effect has led to the development of all these subsequent defects. So we need to understand that. Before understanding that, we need to know that the sequence has been divided into four categories. If we understand all those four categories, we understand sequence altogether. So what is the first category? So the first category is malformation sequence. What is meant by a malformation sequence? The malformation sequence refers to a single localized poor formation of tissue that initiates a chain of subsequent defects. That means what is meant by malformation sequence? There is initially a single localized poor formation of tissue. This single localized pore formation of tissue initiates a chain of events which leads to development of subsequent defects. It can occur in all gradation, basically from near normal to more severe, and the recurrence risk is 1 to 5%. We need to know about one example to understand this. So what is Robin sequence? We commonly know about the Robin sequence. So what is Robin sequence? The initial Single localized pore formation of tissue is the micrognathia. The initial problem is the micrognathia. What does this micrognathia lead to? This micrognathia leads to, what is meant by micrognathia? Micrognathia is refers to a poorly developed small jaw. So this poorly developed small jaw leads to upward and posterior displacement of tongue. This upward and posterior displacement of tongue leads to prevention of closure of the palatine shelves before the 10 weeks of gestational age. This problem leads to development of high arch palate, and also this micrognathia leads to enlarged posteriorly displaced tongue, which in turn causes the airway obstruction. So basically, that Pierre-Robin sequence or Robin sequence, all the problems like airway obstruction, high arch palate, glossoptosis, everything has been caused by this initially localized pore formation of tissue, single localized pore formation tissue, that is poorly developed small jaw in this case. So this has led to a cascade or chain of subsequent defects. So this is a malformation sequence. So you can see the Pierre-Robin sequence here. So there is glossoptosis, micrognathia, airway obstruction, etc. So what is the second type of sequence? The second example is deformation sequence. So what is meant by deformation sequence? In deformation sequence, usually there is no problem in the embryo or the fetus. But what is the problem? The problem lies in the mechanical forces. There are some mechanical forces which result in altered morphogenesis, usually of the molding type. This usually is associated with good prognosis and a very low risk of recurrence. What is the example of that? So the classical example of that is the Potter sequence. In Potter sequence, there is originally no problem in the fetus. The fetus or embryo is perfectly fine, but some mechanical forces happen. What are the mechanical forces? The mechanical forces is oligohydramnios. Oligohydramnios in itself can be caused by a lot of things. It can be caused by a posterior urethral valve. It can be caused by bilateral renal artery stenosis or something else. But whatever it is, the problem is oligohydramnios. That leads to mechanical forces, abnormal mechanical forces, which leads to fetal compression, and this fetal compression leads to multiple things like abnormal limb position, facial dysmorphism, and pulmonary hypoplasia. So this mechanical force or abnormal mechanical force leads to altered morphogenesis. So this is a deformation sequence. So you can see the Potter sequence or oligohydramnios sequence here. There is less amniotic fluid, which leads to abnormal fetal compression, which leads to all the problems. So what is the third variety of sequence? The third variety of sequence is disruption sequence. So what is meant by disruption sequence? In disruption sequence, the normal fetus, just like deformation sequence, the normal fetus is subjected to a destructive problem and its consequences. That destructive problem may be vascular, may be infectious, or may be mechanical. So what is the example of that? The classical example of that is amnion rupture sequence, also known as amniotic band sequence or something like that. So what is amnion rupture sequence? The fetus is normal. Basically, the fetus is normal here, just like deformation sequence. But destructive problem happens. What is the destructive problem? The destructive problem is the disruption of the vascular supply to the embryo. What it leads to? It leads to rupture of amniotic sac in the first trimester. That leads to leakage of amniotic fluid. That leads to fetal compression and fibrous band formations. What do those fibrous bands do? These fibrous bands directly harm fetal parts, leading to complications like amputation, deformation, and constriction. So basically, here also the fetus was perfectly fine, but some destructive problem happened in form of vascular supply disruption or something like that, and this led to a cascading of events which led to multiple problems. So this is disruption sequence. So you can see the disruption sequence, classical example amniotic band syndrome here. The amniotic bands constrict various fetal parts, which leads to problems like this, and amputation of complete limbs also. So what is the fourth category? The fourth category of sequence is dysplasia sequence. So dysplasia sequence means the word dysplasia itself refers to lack of normal organization of cells into tissues. Normally cells are organized into tissues, but if the cells organized into tissues in an abnormal way, that leads to dysplasia sequence. What is the classical example of that? The classical example of that is neurocutaneous melanosis sequence. So in neurocutaneous melanosis sequence, what happens? There is abnormal post-zygotic development of melanoblasts. So melanoblasts develop abnormally. So due to abnormal development of melanoblasts, the cells migrate to the meninges as precursors to malignant or benign melanocytes. So these malignant or benign melanocytes lead to formation of congenital melanocytic nevi and melanocytic tumors in the leptomeninges. So initial problem, what is the initial problem? The initial problem is abnormal organization of cells into tissues, especially here in this case the example is melanoblasts. So that leads to a sequence. This example is neurocutaneous melanosis sequence and it comes under the category of dysplasia sequence. So you can see the neurocutaneous melanosis sequence here. There are abnormal large congenital melanocytic nevi and there are meningeal tumors. So now we have learned about the definition of sequence and the various types of sequence. So what is syndrome? Syndrome refers to multiple structural defects. There are multiple structural defects that cannot be explained on the basis of a single initiating defect. This is the main difference between sequence and syndrome. In sequence also there were multiple structural defects, but all of those defects could have been explained on the basis of a single initiating defect and its consequences. But in syndrome, they cannot be explained on the basis of a single initiating defect and its consequences, but rather appear to be a consequence of multiple defects in one or more tissues. Multiple defects in one or more tissues lead to multiple structural defects. This is the definition of syndrome. So most commonly the syndromes are thought to be due to a single cause. The classical example you can think of is Down syndrome. The initiating or single cause is the trisomy 21 or a Robertsonian translocation. That single cause leads to multiple structural defects. For example, intellectual disability, congenital heart defect, hypothyroidism, single transverse palmar crease, Kennedy crease, all those things. But can all those be explained by a single initiating morphological defect? Can a single morphological initiating defect explain the formation of congenital heart defect and congenital hypothyroidism also? No. So the multiple structural defects present here cannot be explained by a single initiating defect and its consequences. That's why it is called a syndrome. So you can see there are multiple myriad of features in Down syndrome, but those cannot be explained by a initiating single morphological defect. The problem is a single cause, most likely in this case is trisomy 21. So this is a syndrome. So after gathering all the information and after asking those three basic questions, we have to classify any single baby with dysmorphic features into one of these six categories. What are the six categories? Malformation syndrome, malformation sequence, deformation sequence, disruption sequence, dysplasia sequence, and malformation association. How do we classify that? So we have to first think what is the nature of the initial problem or what is the nature of the problem in the child. The nature of the problem, is it poor formation of tissues, is it mechanical, is it destructive, or is it deregulation? You can think of the answer easily. If the problem is poor formation of tissues, it is coming under malformation. If the problem is mechanical, it is coming under deformation. If the problem is destructive like vascular or infectious, it is coming under disruption. On the other hand, if the problem is deregulation or lack of normal organization, it is coming under dysplasia. So if it is coming under dysplasia, it is coming under deregulation, it will be called as dysplasia sequence. If the problem is destructive or the problem is disruption, it will be called as disruption sequence. If the problem is mechanical indicating deformation, it will be called as deformation sequence. But if the problem is poor formation indicating malformation, the next question we have to ask is it a single localized defect or is it multiple localized defects? If the problem is single localized defect, we have to call it a malformation sequence. But if the problem is multiple localized defects, we have to call it a malformation syndrome. But more often than not, a clear distinction between malformation sequence and malformation syndrome cannot be made. for mainly like you cannot know whether this is a single localized defect or multiple localized defects. In that case, you can use an umbrella term like malformation association. So this is how you approach to classifying a baby with dysmorphic features. So thank you. If you like this video, please share with your other friends.